Hello, welcome to my podcast and my YouTube channel. Today, my guest is Suzanne Rutti. She's a clinical social worker. She is specialized in the treatment of trauma of all ages. She owns Ruti Counseling and Consultation in Columbus, Ohio, here in the US. She is certified in MDR treatment for trauma. And for those who don't know what that is, please listen to my episode number 36, because we explain what that is. This is not the focus today. And she also offers training and consultation across the nation. Suzanne, thank you for being with us. Welcome to the podcast.
Thank you for having me.
So I wanted to talk to you about something that we, even for us, I think for us counselors and mental health professionals, we don't talk about this very often, which is pre-verbal trauma. So let's start by explaining what that is.
Sure. Yeah. So if you think about how that's called pre-verbal, right, is it's trauma that happens before we have language. So it's in our young developing years. It could be, it can encompass any kind of trauma. Mostly what we think about are things like abuse, physical, emotional, sexual abuse and neglect. But really, it could be medical procedures. It could be a traumatic birth experience. It could be the absence of a caregiver. So it really encompasses anything that could be stressful or traumatic to a very young child who hasn't yet formulated language.
Mm-hmm. And it can be one single event or it can be ongoing.
Yeah, it could be, just like with trauma in general, some people have what we call chronic or complex trauma when they have, trauma that happens over, periods of time, so things like sexual abuse and violence and exposure to domestic violence, things like that would be things that they would be exposed to over time. Complex trauma would be things that, it has that betrayal element. So it's trauma that's caused by the people that are supposed to take care of us. But it could
Mm.
also be single incidents. It could be, a single thing that happened or, an accident or a medical procedure or something that happens one time that we just don't formulate language to be able to describe later. So if we don't have the
Mm-hmm.
language for when it happened at the time, we actually won't be able to have that language, when we're 8 or 10 or 25 or 40 years old. We actually can't access that language to describe the experience.
Well, but still the impact is there, right? It doesn't mean that it didn't leave the
Absolutely.
imprint.
Absolutely. Yeah,
Mm-hmm.
so we can see that in a lot of different ways. Sometimes we see more what we would call obvious or outward symptoms, externalized symptoms, like anxiety or behavior problems or difficulties in relationships, but it could also be more of the internalized symptoms and experiences, more like depression and anxiety and dissociation and things like that.
Mm-hmm. And when you just mentioned internalized, like mental illness, when does that start showing? What is the earliest age that a
Yeah, I mean,
child
it can
can
really show
develop
up.
that?
Yeah, it could show up anywhere. A lot of times, what I tend to see when I'm working with really young children is parents are either noticing, like I said, the external behaviors, so behavior problems, things that we see where kids are acting out or they're dysregulated emotions. But what a lot of what I see are parents coming in when there's regressed developmental milestones.
Mm.
So, maybe a child was potty trained and all of a sudden they're having accidents again, or maybe their language is starting to regress, or, so we sometimes are looking for significant changes in functioning or presentation in the really young
Mm-hmm.
children.
And I'm sure that's a huge challenge for some parents or caregivers because
Oh, yeah.
one thing is when you know what happened, but it can be something they witnessed, right? It doesn't necessarily have to be something that happened to them or was done to them personally.
Right. Yeah. Trauma doesn't have to actually happen physically to our bodies. It could be something that we witness or experience or even think is going to happen. Could also be traumatic. So the threat of harm could also be traumatic to a child. Yeah. So it's
Mm-hmm.
not always something that the parents have the language for. Oftentimes parents, if they weren't there for the thing that happened, they may not have the details, and we may never get, all the details of what actually happened, which can be really difficult for parents to understand when they want to know, of course, what happened
Mhm.
to their child.
So it's usually parents who, of course, know their children and they notice that there's something off or some kind of change that has no explanation for.
Yeah, parents or any caregivers, sometimes it's children who are in the care of, foster care, or kinship care, have been
Mhm.
adopted. But it's anybody that's, typically seeing them day to day and noticing that disruption in functioning. Or sometimes if they're school age, it may, be a teacher or somebody at school that's noticing that something's not quite right, or that something's different, something has changed.
Mhm. And we also need to take into consideration the age of the child, right? Because some behaviors are normal depending
Mhm.
on the age. I'm thinking of separation anxiety. If you have, with a few months up to 1 year, a year and a half, that's, moderate separation anxiety. That's normal, even toddlers. But if you see that in a child that's 6, 7, 8, 10 years old,
Yeah.
then that should catch your attention, right?
Yeah, yeah. So it's absolutely keeping developmental stages in mind, which is different for every child. Everybody hits different milestones at different times, but we do have some, what we would consider typical ages for things like separation anxiety that might be developmentally appropriate. The other thing to look for is if suddenly there's an onset of separation anxiety. So maybe it's a child who is ordinarily doing fine,
Mhm.
going to school or separating, and now suddenly they're having difficulty. Or if it's, like you said, going on for too long, maybe that they're
Mhm.
reaching ages when other peers their age may not have the same kinds of concerns, might be an
Mhm.
indicator to look for. I wonder if there might be something else here, some other source of that
Mhm.
anxiety.
Mm. So I'm thinking that most of the things that you mentioned in terms of symptoms and what to look for are behavior related, right? So changing, maybe they're more quiet, the change in mood, their mood is different. What else should parents watch for? Or parents or caregivers or even teachers, as you mentioned?
Yeah, so we did talk about some things that you may see with externalized behaviors. So looking for, again, something outside of what's developmentally appropriate. So it's appropriate for kids to have, some tantrums and to be frustrated. They're still figuring out how to navigate emotions and express emotions. But if we're seeing really significant behavior problems, outbursts, anger, aggression, kinds of things, would be some behaviors to look for. We talked about some of that separation anxiety. Also looking
Mhm.
for either regressed or not meeting typical developmental milestones. So things like potty training, interpersonal relationships. Kids at certain ages should be, interacting with peers and learning and
Mm.
sharing and playing. And if you're seeing some things that don't seem quite typical for a child in terms of relating to peers, or how they're interacting with peers, might be some things to look for. And then something that gets overlooked a lot is what we call dissociation. And so
Mm.
dissociation is, it's a coping strategy. It's a survival strategy that kids can learn from a young age. When we think about trauma responses, we talk a lot about, fight, flight, freeze. There's
Mhm.
also a collapse response, which is kind of which is the safest response, right, is to not to fight or to run away,
Mm.
but to kind of withdraw or
Mhm.
separate from the experience, which, especially with very young children, is typically the safest way for the brain, is to go away, right? So
Mm.
to escape or to daydream or to
Avoidance.
check out. Yeah.
More like avoidance.
It's an avoidance. It's a safety strategy, and so that's something to look out for also. So are those kids that seem really daydreamy,
Mm.
or spaced out or checked out, is often an indicator that there may be some trauma there.
Mhm.
That's something that really gets overlooked because it's not usually seen as a big problem, right?
No,
Unless it's
yeah,
getting in the way of school or
yeah.
getting in the way of
Mm.
learning.
And sleep problems as well, nightmares that
Yeah,
shows up too.
yeah. Yeah, and again, some of that could be normal. So, some kids have nightmares, but if it's really intrusive, or if it's getting to the point where they're scared to go to sleep, or they're having them very frequently, those would be some things to look out for. If they remember their nightmares, you could talk about kind of what they're about. They're not always about the actual trauma that happened, but maybe
Mm-hmm.
the same themes, maybe around safety, or feeling scared, could be possibly some indicators
Mm-hmm.
of something else.
Suzanne, can you talk about how trauma at that early age affects the brain? Because in other episodes, we've talked about adults and adolescents and how that affects the brain. But what kind of impact can it have when they're so young?
Yeah, the brain response is the same. So,
Mm-hmm.
if you've talked in other episodes about, what I was just kind of referring to, that fight, flight, freeze, or the collapse responses, those are stress responses, right? When something scary or something happens that the child's not prepared for, and those memories of the stressful things get stuck in that part of the brain. So they get stuck in that emotional part of the brain that handles scary stuff. And so for kids, if you think about, if they're starting from an early age to have these memories kind of accumulating in that stuck part of your brain, then anytime there's things happening in the environment that remind the child of the scary stuff that happened, they're going to have that same trauma response. So that stuff that's kind of stuck in there is causing them to continue to have trauma responses, sometimes even after there's not anything scary happening anymore. So
Mm-hmm.
that can cause, when somebody's in that trauma response so often, that impacts learning, right? Because they're not able to use the parts of the brain that should be engaged in learning and interacting with the world, and all that kind of stuff gets disrupted because they're functioning so much in that frozen or scared
Mm-hmm.
part of the brain, that limbic
Yeah,
brain.
and I would imagine that it has an added challenge, that the fact that they can't really give language to it, right? Because there
Yeah,
is no language there.
yeah,
So that makes it even more complicated, because one
yeah,
thing is to say, well, yeah, because I remember this is what happened. But if it's not there, the language, that's really
yeah.
tough.
And sometimes we see too, so what looks like people getting kind of stuck at developmental stages. So when there's a significant amount of trauma around specific ages, those might be clients that maybe they're teenagers, adults, but they still seem to be kind of emotionally functioning younger. And
Hmm.
sometimes that's because of the ages that they may have experienced trauma.
Hmm. And how does that affect the development, just the normal development of the person when they have that kind of trauma? Does it show up
Yes.
throughout their lives?
Yeah,
In
yeah.
what
So it can. I
ways?
mean, if it's unhealed, we'll
Mm-hmm.
talk a little bit about, what do we do about it, or how do we heal some
Mm-hmm.
of that. But I do work with, adults, and even older adults who have unresolved preverbal trauma and trauma from childhood, and it still is manifesting either with physical symptoms or emotional symptoms, but lots of times with how we navigate relationships. So they may, be coming in initially because they're having difficulty with relationships, or holding jobs, or managing the stressors of having children. But a lot of that could be rooted in some of those really early experiences where they started formulating
Mm-hmm.
some negative beliefs about themselves.
Mm-hmm. And I would imagine that affects to your self-image, because
Oh yeah,
children, they
yeah,
have this tendency to, whatever happens, even their parents divorce or domestic violence, it's their fault. They have
yeah,
this idea that they did something to deserve it. So
yeah.
what kind of impact does it have on the way they see themselves?
Yeah, yeah, so absolutely. That's, those young ages are when we're figuring out who we are. And a lot of
Mm-hmm.
how we do that, somebody told me once, I forget who, a trainer back when I was early getting trained, is that if you think about holding it like a hand mirror, the way that we develop when we're young is all this. It's all, it's all um, it's all what people are telling us, or what we're saying, you know,
Mm-hmm.
what they're saying to us or how we're interacting with them is about, like, that's how we develop who we are, rather than
Mm-hmm.
kind of turning that mirror outward and being able to have our own experiences as well as experiences outside. So it's so much based on, you know, if someone looks at you the wrong way, or a peer says something to you, or a parent says something to you, that gets so internalized from such a young age. And if we look at kind of, you know, adaptive information processing and, you know, different things about how we learn, those early experiences, that we start to form beliefs like I'm bad or I'm not good enough, then every time we have other experience in our life, they kind of get filtered through those other experiences. So if you already believe, I'm bad or I'm stupid, then the child goes to school, has an experience with a peer, they're going to likely internalize that belief again. Even if the kid didn't say anything directly negative about them, there's a higher tendency to just keep having those beliefs about ourselves reinforced. So it can really impact self-image and,
Mm-hmm.
self-blame, value, responsibility, all kinds of things that we can
Yeah.
develop. Yeah.
You talked about relationships, and this is something that I also try to focus a lot my interviews on, because I do believe in the power of relationships as a healing tool.
Hmm.
So how does it show up in relationships when you have this kind of trauma?
Yeah, it can show up a lot of different ways. Some of it could be dependent on the kind of trauma that the child may have been exposed to. We talk a lot about attachment as, you know, clinicians in this field, and so when children grow up and have access to healthy, safe caregivers and have, you know, secure, safe relationships with caregivers, we may be more likely to have the ability to engage in safe, healthy relationships with other people as we grow older. If we don't have those needs met when we're younger, you know, we can respond in different ways. Some ways would be, you know, to develop a belief that I can't trust anyone. You know, if the person that was supposed to take care of me was hurting me or was not safe, that, you know, we can develop these beliefs around it's not okay to trust people. So we might be more likely to keep people out or keep people at a
Mm-hmm.
distance or kind of have a wall. Other people might really grasp at relationships. They may be so desperate to have a relationship of, you know, someone who cares about them, that sometimes we see those, you know, those behaviors where people are really, um, you know, having extreme behaviors in relationships, like you don't love me or you don't want to be with me, or, you know, kind of that black and white thinking can kind of happen because they didn't get, you know, those needs met in that formative attachment. And so
Mm-hmm.
it can absolutely disrupt relationships. There's also, you know, um, just generally trauma symptoms, you know, could get in the way of relationships at times if people tend to have, you know, less tolerance for things that are stressful. Than when there's conflict in a relationship, the conflicts could get really big, or they
Mm-hmm.
could really avoid conflict depending
Yeah,
on kind
like
of their
shutting
coping
down,
style.
and yeah,
Hmm.
I would
Yeah.
imagine that it would also have an impact in terms of, maybe I just said shutting down, but numbing your feelings, and
Hmm.
maybe addiction and things like
Yeah.
that.
Yeah. Yeah.
Yeah.
So when I talked earlier about dissociation, kind of that shutdown avoidance response, if that's learned from a young age, they may also kind of start seeking things out to numb as we get older. So as stressful things keep happening, you know, people may be more likely to depend on substances to not feel, or other things. You know, we live in a society where we have access to a lot of things that can help us numb and check out, like technology and social media and all that kind of stuff. So those might be people that are, you know, their partners are complaining they're always on their phone, or they're lost in their work, or, you know, that can be
Mm-hmm.
a protective strategy too.
Mm-hmm. When we think about mental illness, are there any specific diagnoses that are more present in this population?
Yeah, I mean, I would love if everybody got accurate trauma diagnoses.
I know, but
Yeah,
that's
it's
frustrating for all of
yeah,
us, right?
yeah. It's just not always the reality. You know, a lot of people grow into, you know, teenagers and adults and get diagnoses like depression or anxiety, sometimes even diagnoses of bipolar disorder, borderline personality disorder, substance use disorders. But if we look at kind of the root of all of it, we might be able to see, oh, these symptoms also overlap a lot with trauma disorders, right? Same with
Mhm.
ADHD. A lot of kids with trauma get diagnosed with ADHD because they are dysregulated. They can't pay attention. They're not learning. They're, all the complaints that the teachers and the parents have, but it's because they can't, regulate and stay focused because they're having trauma response. So that's a
Mhm.
really, in kids, I see them most often misdiagnosed as ADHD and oppositional defiant disorder.
Disorder. Yeah. I'm curious about treatment because I don't treat kids.
Hmm.
I only treat adults. And I'm always mesmerized by how, I mean, how do you do the work with kids, right? Especially when there's something like this, that, trauma before they even developed language, their capacity to
Hmm.
communicate or communicate, through speech. So can you walk us through what an, unusual session looks like, just to give us an idea of how treatment works for, and I'm talking
Yeah.
about kids, and you
Yeah.
treating kids, not adults who were
Right.
victims of,
Right.
of preverbal.
Yeah, so you did mention in my bio that I'm an EMDR therapist, and I won't go into, too much of the technical of that because I know you did another episode on that. But I do look at my cases through that lens of, the goal being eventually reprocessing the trauma. So the eventual goal is to work through those trauma memories, help actually shift and get them unstuck from the part of the brain that's continuing to have those trauma responses and those emotional responses. But my approach with kids has to be different, because they, like you said, they may not have the language or may not stay as engaged with talk, traditional talk therapy kind of stuff. So I do integrate a lot of play therapy into the work that I do. As much as I can keep kids kind of engaged, and also knowing that for a lot of kids, part of their trauma symptoms is that they're not going to be able to sit still and regulate. So things that
Yeah.
I can do to help their bodies stay regulated, like play. And the goal would be, first we would want to work on stabilizing their symptoms. So first we're working on, learning coping strategies, some mindfulness strategies, different things to help them to be able to stay in the here and now and not
Mm-hmm.
use some of those protective coping strategies that might not be so helpful to them. And then eventually the goal would be to identify some of those early periods of time, or if we know what the trauma was, or we know that there was trauma that happened, then we would specifically target those trauma memories. Sometimes with kids, because they don't have that language for the past stuff that happened, what we're actually targeting or focusing on in the day-to-day sessions might be things that they're having trouble with now. So maybe a fear of the dark, or like you said, trouble
Mm.
sleeping, or getting in fights at school. But by activating that that stuff that's distressing them now, the goal is that hopefully we may be able to activate some of the stuff that happened in the past, that that's kind of the root of those behaviors. I do sometimes, if there's a healthy, secure, safe parent or caregiver accessible that might know a little bit more about the trauma they experienced pre-verbally, then sometimes I do include them in the treatment process,
Mm.
to help support the child with processing their trauma story,
Mm-hmm.
by kind of using
Yeah,
them.
yeah. I was going to ask, I mean, when
Mhm.
do you decide whether or not to include the parents?
Yeah. I mean, they're all included in some way, but how much I include them is really dependent on their relationship and the nature of the trauma. So if I'm working with a child who really has a really difficult time with attachment, who's, has a hard time trusting, is reactive to caregivers, or takes out a lot of their aggression on the caregivers, then I would be including that caregiver to see if we can work on repairing some of that attachment, and then maybe get to the trauma material. um, there are some situations that, just because of the nature of, maybe a parent might have their own trauma and might be not as stable to be able to really participate in those types of the treatment that we're working on. So I, would love for all the parents to be able to have access to treatment too, but lots of times they don't put that time for themselves in, just because of, they're busy, they're stressed, they just want their kids to feel better. So
Mm-hmm. Can we give some tools to my audience? Because I mean, they're not therapists, they don't
yeah.
have the skills, and also it can sometimes not be their kids, but they know a kid that they look at, and even can be, a kid that plays with their kids. So can
Mm-hmm.
you give them tools on how to help these kids if they're not going to therapy?
Yeah, one big thing is that research does suggest that kids who've been exposed to trauma, if they even just have one person in their life that's a stable, safe, consistent adult, that's a big indicator of resiliency. So if it is somebody that you're close to in your life, or if it's a student in your class, or a niece or a nephew or someone that you're close to, if you can be that consistent, safe person, that could
Mm-hmm.
be, a game changer for symptomology later in that person's life. But other things would be, helping them to stay regulated. So if there are, ways that you could help support them, even simple things like if a kid seems, what I mean by dysregulated is like if they're, seeming really anxious or irritated, or like we were describing before, really kind of daydreaming or checked out, you could just try to bring them to the present. So if you could just kind of ask them, about the here and now. Sometimes it's as simple as like, hey, what day is it? Or what's the weather like outside? Or what color
Mm-hmm.
shirt am I wearing? Are things that are grounding to bring children to the present. Could take it, further than that. I play I Spy a lot with kids. Can help kind of get that brain uh, back engaged. That's the part of the brain that helps, with rational thought and interacting with the world. So if kids seem like they're kind of dysregulated or having some kind of stress response, just the simple bringing them back to the here and now could really help them to be able to move through the rest of the day.
Yeah, you're talking about the kids who check out, and I'm thinking about the new generations. I mean, how do
Yeah.
you know if they're checked out or they're just spending hours on their phones because everybody else does? That's a
Yeah.
tough one, isn't it? To know
Yeah.
if that's a coping mechanism or they're just doing what everybody else is doing.
Right. Yeah. It's like the chicken or the egg, right? What is it?
Yeah.
If sometimes an indicator to me is if then when we're trying to do something in the here and now, like if I try to do, meditation or a mindfulness practice with them to have them in the present, if that's really hard for,
Mm.
a teenager or an adolescent to do, if that's really uncomfortable to just be in silence without their phone, that that could be an indicator to me that they're using that technology to like you said, check out. But again, it's hard because it might just be that they don't ever not have their phone. They're always on
I
their
know.
phone, and
I
so
know.
yeah, it makes it harder.
Yeah,
Um,
I'm thinking even basic things, trying to have them help you cook something, and they
mhm,
be with you for a minute, and then they go check their phones again.
yeah.
Yeah, that's a really tough one.
Yeah, it's hard because society and technology has created this like instant gratification. And so sometimes we see that now behaviorally too, even if they're not engaged in the phone. It's like they want something, they want it right now because they're used to being able
Hmm.
to get that instant response from peers or from technology. So
Suzanne, thank you so much. Where can they find you?
yeah, so you can find us. It's SuzanneRutti.com is our website, and it's a counseling practice in Columbus, Ohio. But we also do a lot of consulting and training. And
Hmm.
my goal and my hope is that more people can learn about trauma um, and be able to find support and help and healing.
Hmm. I'll make sure I have your website on my notes.
Thank
And
you.
if you have any other resources that you find are important, you can just send me and I'll add them to the notes, okay?
Great.
Thank you for your time, for going up in the attic to talk to us.
Thank you.
For those who will watch this interview on YouTube, you see where she is.
Yes, I live in a home with a toddler, so I find the quietest space I can at all times to do my work.
Yeah.
So, yeah,
How
thank
so? How is it to be a mother with a toddler and to be in this field? I'm
Oh,
sure
yeah.
Are you like overprotective, or you really pay attention to everything? Or
Yeah, that's such a great question because I really noticed I'm pretty passionate about secondary trauma, which is, the nature of, the side effects of being a clinician working with trauma is, of course, we take on, some of those symptoms and stories and things that we hear. But I've talked about, when I had my child, that I really started noticing some of those secondary trauma symptoms kicking in even more because now you hear the story of something that happens to a child and you picture your child, right? It's a natural thing that your brain
yeah.
does. And so, really having to check my boundaries around, just some of the work that I'm
Mm-hmm.
doing. There might just be some cases that just wouldn't be a great case for me to take. If I have a 2.5-year-old, I might want to think about, 2.5-year-old on my caseload and what that might feel like just for my self-care.
Mm-hmm.
But I also have to balance it and remind myself that uh, there are good things happening in the world too, and not everybody gets hurt. I try to, she's my self-care. I see her happy and healthy and know that she's safe and living in a home where she's,
Yeah.
being looked out for. So
And the developmental too stages,
yeah,
and so just being able to say, well, this is part of her. This is
yeah, yeah,
accurate in terms of age, and
yes,
I'm
yeah,
not seeing too much here because I'm just thinking of my sister when she had a child. After she had a child, she could never watch any movies that kids got hurt.
yeah,
But now
yeah,
I can't watch those anymore. So it
yeah,
does change your lenses. And
yeah, yeah. And I do know some people that after they have kids, they do feel working with kids isn't right for me right now, just because of that. I hope that I can continue to find a balance, and it does. That's a great point that it does really help to have that knowledge about developmental, what's kind of normal or typical of
mm-hmm,
development, because that's also something that's been really helpful to parents that I'm working with, is they don't always know, for instance, what's normal sexual behavior for different
mm-hmm.
ages of
Yeah.
children, and so sometimes being able to hear like, oh, okay, so maybe that's might not be a trauma response, or maybe that doesn't have to mean that they were sexually
Mm-hmm.
abused, because lots of parents, as soon as a kid has sexual behavior, it's the immediate thought is, something happened to them. But some of it can be developmentally appropriate. So
Yeah.
yeah,
Well, I'm glad you're still treating kids, and I hope you do for a long
thank
time.
you. I do too. I do enjoy it.
Thank you. Thank you for the interview.
Thanks, Paula.